That looks promising. Are we on Zoom as well? We're good to go?
Yeah.
Perfect. So thank you for inviting me to come. Thank you for having me. My name is Colin Lundeen, and as mentioned, I work up in Duncan, one of the 2 urologists there. I did my training here in Victoria, got my start in urology with a lot of the urologists that are here now. So I can thank Dr. McCauley and Dr. McCracken and Kinahan and the group here for getting me interested in urology. And now a few years later, here I am getting to come down and give a talk. We're going to talk a little bit today about radical prostatectomy and sort of the whole journey from beginning from diagnosis all the way through. Conflicts of interest, things that you need to know. I'm a surgeon, I am a urologist, I perform radical prostatectomy, so there is always some sort of inherent bias with a urologist talking about radical prostatectomy. So what we'll chat about is diagnosis, management options. What is a radical prostatectomy? I'll just walk you through a few of the main steps so you have some idea of what's actually going on, and then what to expect. And these are the things that really matter to you. What goes on during surgery doesn't matter all that much because you're either asleep or have a spinal anesthetic. You have no idea what's going on, but it's what to do beforehand, what to do afterwards, and what to expect in the long term. So for diagnosis, everyone has a different way that they got to their diagnosis of prostate cancer. For most men, prostate cancer is diagnosed because of an elevated PSA, prostate-specific antigen blood test. So at some point, probably a family doctor said, we're going to do a blood test for you, or you asked to have one done, and you got the PSA and it was probably a little bit elevated. For a smaller percentage, it was picked up because your rectal exam was a little bit funny. There was something abnormal, a little nodule, a little irregularity picked up by a family doctor or someone else who was looking after you. And then for some men, it happens because of voiding symptoms. So I saw 2 men in my clinic yesterday who presented with metastatic disease, and the reason being their kidneys had shut down because the cancer had completely blocked off their urethra and they couldn't pee. So they ended up being diagnosed because of urinary retention and inability to void, and I had to do surgery on them to help them pee again. How do we diagnose prostate cancer? So now as you go through your PSA testing, your rectal exams, for some of you it may have been years from the time when your PSA was a little bit high to when you were diagnosed. For other people, it's as soon as your PSA gets checked, you're diagnosed very shortly afterwards. 2 main ways of diagnosing. There's the standard method, the prostate biopsy, typically done transrectally, an ultrasound probe up your rear end in an unpleasant fashion, and they take multiple samples to get a diagnosis. The other option, as I mentioned for the 2 people that I recently diagnosed, some men have prostate cancer diagnosed either incidentally because they came in with bladder symptoms, they couldn't pee, they were having troubles peeing. We take them to surgery, we resect some tissue so they can empty their bladder more successfully, and the pathologist tells us, oh, by the way, there's prostate cancer in the specimen. So most men have a prostate biopsy, a formal biopsy, and for some men it's an incidental finding just picked up because something else was happening. Once you get your biopsy, then we have to figure out, okay, what kind of cancer is it? First of all, is it standard adenocarcinoma of the prostate or some funny type? And how aggressive is it? So the first thing we look at is the biopsy results. We say, how aggressive are the cancer cells? And there are 2 scoring systems. For a lot of men here, you have probably heard of the Gleason score. Gleason score it's a goofy score because all that matters is from 6 to 10. So 1 through 5 doesn't matter, nobody pays attention to it. So it's a little tricky when you say, oh, you have a 6 out of 10, and people think, oh no, that's bad, it's above 5. But really 6 out of 10 is cancer that we often don't even treat nowadays. So Gleason score is slowly being replaced, potentially, by the grade group score, which is just from 1 to 5. 1 is mild cancer, 2, 3 are what's called intermediate risk, and then 4 and 5 are the high risk disease, which correlate directly with the Gleason scoring. So grade group, Gleason score, these are the terms that you may hear along the way as you look at a diagnosis and look at treatment options. And then we take that Gleason score and we combine it with the PSA value and what the prostate feels like, the physical exam, and we get a risk classification. And so the basics are, if you have low risk or low aggressiveness scale, low Gleason score, low grade group score, cancer, and your PSA is low, then you are low risk. Many of these men will go on to active surveillance, just watching the cancer. Intermediate risk, you don't have to worry about all the details here, but either intermediate risk in terms of the Gleason score, Gleason 7 disease is intermediate risk, a PSA that's a little bit higher, somewhere 10 to 20. And then if we can actually feel cancer on the prostate and it's in both sides of the prostate, that's when we look at intermediate risk disease. And then there's high risk disease. And these are the cancers that are quite aggressive. So you show up with a very high PSA, you have a biopsy showing grade group 4 or 5, which is equivalent to Gleason 9 or 8, 9, or 10. Or when we feel your prostate, it actually feels like the cancer is out of the prostate already, sort of extending into the fat around the prostate. So as a urologist, as we look at all the information we have, these risk categories make a big difference when we're looking at who should have what types of treatment. And one thing to note, this is all for localized prostate cancer. There's localized and then there's metastatic. And so after we look at the risk classifications, then we look at what's called staging. Staging tells us, is there cancer somewhere outside of the prostate? Prostate cancer is a highly treatable and highly curable disease if it's caught early, just like many cancers. Prostate cancer in many circumstances can be slow growing. And so there is some time to figure out how best to treat you and for you to be able to make decisions about your care. Standard staging options are a CT and a bone scan. Not everybody needs a CT and bone scan, because if your PSA is 3 and you have grade group 1 or Gleason 6 disease, low risk disease, the chance of you having metastatic disease is very close to 0. It's going to be well under 1%. As you get up into intermediate risk with a high PSA or high risk disease, Gleason 8, 9, or 10, then we get a little more concerned and we get a CT and a bone scan. The CT scan is going to look at everything, typically abdomen and pelvis, not usually the lungs. CT scan is going to show us all the organs inside the abdomen. It's going to show us the lymph nodes beside the prostate where cancer typically spreads to first. And it gives an idea about bony involvement as well. The bone scan purely shows us uptake in the bones, looking for bony metastatic disease. Other things that may be used are MRI of the prostate, which is a little more accurate, looking for local extension of prostate cancer. MRI, some men may have had that in their journey before having a prostate biopsy as well. The PSMA PET scan is a new imaging technique. It's currently either private pay, costs about $3,000 at one site in Vancouver, or it's done through a clinical trial through the BC Cancer Agency. And the PSMA PET scan is our most accurate way of picking up prostate cancer, still by no means perfect though. And so if there are questionable findings, say a CT shows, oh, there's a lesion in one of the bones and we think in one of your vertebrae and we think it's cancer, but the bone scan doesn't show it, then sometimes we're able to get a PSMA PET scan that will help clarify if that is truly metastatic prostate cancer or localized. Metastatic prostate cancer, very different treatment than localized prostate cancer. And so again, if we find metastatic disease, if the staging shows that there is cancer outside of the prostate, into the lymph nodes, into the bone or other organs, then radical prostatectomy is no longer an option. Radical prostatectomy is used for local disease that is contained within the prostate. There is a trial going on in Vancouver run by the head of the urology department there, Martin Gleave, looking at can we benefit patients by treating metastatic prostate cancer patients with a radical prostatectomy. And so that's underway right now, and there will be questions in the future whether that's going to be useful. So what are the management options? Now, I'm sure we have a whole slew of people here who have either had treatment already, maybe at multiple different stages of disease, and some people who are probably looking into what they should be having done about their prostate cancer. For localized prostate cancer, so disease that's within the prostate, there are two standard options for treatment. There is surgery with a radical prostatectomy, or there's radiation. Now, surgery, there are three different ways to approach surgical intervention for prostate cancer. There's the open approach, which on Vancouver Island is what everybody is doing. And in most of British Columbia, that's what people are going to be having done, is an open radical prostatectomy. Then there's a laparoscopic approach, which is much more complex, requires additional training, and the outcomes aren't really any better than the open approach. And so there are probably a handful of urologists in Vancouver in the Lower Mainland who perform laparoscopic prostatectomies. And then there's robotic prostatectomy, or what's called robot-assisted laparoscopic prostatectomy. So you have a very fancy, expensive $5 to $10 million machine. A urologist sits with their coffee cup at a station, at a console, and you operate a fantastic machine that makes the job much easier for the surgeon because they're sitting in a comfortable chair as opposed to leaning over sweating. But the findings so far from open versus robotic surgery is that robotic surgery might have some small benefits, but they're not big enough to make the robot pay off in a public healthcare system. So if you go down to the States, everybody gets a robotic prostatectomy because before there was any evidence that it helped, people just thought it helped, and people thought it was a good idea. It sounded interesting, and from a marketing perspective, which is big in the States, everybody wanted to have a robotic prostatectomy. So that's how almost everywhere in the US, people will have a robotic prostatectomy performed rather than an open procedure. In Ontario, there are a few robots at the main teaching centers. In British Columbia, there is one robot, or I think two robots now, but they're both at Vancouver General Hospital. So if you were interested in a robotic prostatectomy, you could potentially ask for a referral over to Vancouver, and there are 3 or 4 surgeons over there who are performing these surgeries. Now, in Victoria, Dr. Metcalf, Dr. McCracken are both trained in robotic prostatectomies, but they came back to a place where there is no robot. And so there's talk in Island Health that there may be a robot eventually, and it may be an option eventually. But currently, again, the benefits are fairly small. The thoughts are slightly lower blood loss by 100 to 200 milliliters, which doesn't make a big difference in recovery, and slightly quicker return to continence. So return to you being able to keep your urine in the body, which is one of the main side effects of a robotic or a prostatectomy in general. No big difference in cancer control from what we can see so far. So those are the 3 different options for a radical prostatectomy. Then there's radiation, and Dr. Alexander will be here next month. He's one of our radiation oncologists at the Cancer Agency here in Victoria, and he'll be talking to you a little bit more about what are the options for radiation. So there's brachytherapy, which is the insertion of radioactive seeds or pellets into the prostate, done through a surgical procedure requiring a general anesthetic still, but they just put them in through the skin in the perineum, in between the scrotum and the anus. The seeds go in and they slowly release radiation into the prostate. Then there's external beam radiation or stereotactic body radiotherapy. And these are radiation where you are being hit from outside of your body with radiation that is focused on the prostate. External beam is the standard treatment option, well studied, slightly lower effectiveness long-term than radical prostatectomy or brachytherapy. Stereotactic or body radiotherapy, or SABR is the short form for it, is higher dose external beam radiation. So instead of having 20 sessions of treatment or 30 sessions of treatment, you're going to have 4 or 5. So it's taking the radiation, it's focusing it a little closer in to the prostate, and you don't have to go quite as many times. So those are the standard options. Beyond that, then you have alternatives. And the main alternative is what's called a thermal ablation approach, cryotherapy, or HIFU, which is high intensity focused ultrasound. These are treatments that are, according to guidelines, European, American, Canadian guidelines, these are still somewhat experimental. They are not covered by the public healthcare system. They are private pay. Currently, men who are interested in these options would be sent to Ontario for for their treatment, and it's about $25,000 from what I understand. I haven't had any of my patients go, but some men do go. There will be a program opened up in Vancouver at some point, likely by one of the guys that I trained with. He's trained in these therapies. And so it's still a little experimental. You can have reasonable results, but higher chance of recurrence. The thought with these is they're a little less aggressive. You're going to have fewer side effects. Your incontinence is going to be less. Your erectile dysfunction is probably going to be less. But the thought is that the effectiveness of cancer control is also probably a little bit less. I'm not going to go into too many details about that. And then there are a whole bunch of other things that patients come to me saying, oh, I had a patient today, I heard about nitric oxide. Nitric oxide, I hear it cures everything. And if you go online, you will read 100 different things potentially about different herbs and supplements that can cure prostate cancer. There's no good evidence outside of radical prostatectomy radiation for localized prostate cancer. You are welcome to try anything you want, but you have to realize that without evidence, you may be causing yourself harm. Because if you have localized disease, you are still considered curable. We can treat you, we can deal with your cancer. Once the cancer spreads, and I tell this to my patients who choose not to go ahead with treatment, I say, we may be missing a window. And if we miss that window, then this becomes a disease that will potentially be life-shortening, life-ending. So, who makes a good radical prostatectomy candidate? So, you have two main options. You have surgery, you have radiation. Radical prostatectomy, in general, will be chosen more commonly by younger men. And if someone comes in and is 400 pounds, having surgery, the complication rates go up significantly with significant obesity. And so young, fit men, so men who are diagnosed in their 40s, in their late 40s, which is not common, men who are diagnosed in their 50s will often choose to go ahead with surgery. You have to be willing to accept potential complications. So with surgery, it's a bigger hit to the body up front, which is why for younger men, the recovery is a little bit quicker when you're 50 than when you're 70 years old. Urinary incontinence, erectile dysfunction are the two things we always talk about, and I'll mention that a little bit more later in the talk. So a good candidate is someone typically who is young and who is fit, but in the end, it's a personal choice. So I have some men who I say, you know what, I think you'd do better with radiation, and they go and they talk to the Island Prostate Center, they do reading, and they say, no, I want my prostate removed. And if it's a reasonable decision, your surgeon will probably be happy to go along with it. There are going to be certain cases where it doesn't make sense. Okay. In the end, it's typically a personal choice. So if you tell your surgeon, yes, I want to have my prostate taken out, then they're going to be willing to have a conversation with you about that. And they'll give their professional opinion on how good of an idea they think that is. The reason why younger men typically choose radical prostatectomy is the prostatectomy, you have the erectile dysfunction potential, you have incontinence potential, but you don't typically have long-term complications that we often see with radiation. So complications with radiation are irritation to the bladder and the bowels that can get worse over time. Bleeding in the bladder is something that we see post-radiation. Secondary cancers is something you see post-radiation for some men. So I have probably a handful of people in my practice who were prostate cancer patients and now have bladder cancer as well. Because the radiation, when it hits your prostate, some of it scatters and hits your bladder and hits your rectum. And so there's potential. And those effects get worse over time. So 5 years down the road, probably no chance you're going to have a second cancer. 25 years down the road, 30, 40 years down the road, your risk goes up. The other nice thing about surgery is that it does give you the option after you've had surgery that if there's a recurrence, you have the option of having salvage radiation. So you can have radiation after a radical prostatectomy, but you often won't be able to have a radical prostatectomy after radiation, especially if you were, say, 70 years old when you had your radical prostatectomy and your cancer recurs 10 or 15 years later. Very few men in their 80s will have a radical prostatectomy because the complication rates are much higher. Very few men will have a radical prostatectomy after radiation in general because you're almost guaranteed to have incontinence and you are guaranteed to have erectile dysfunction, and the general complication rates are higher. So just a few little things about what a radical prostatectomy is. So in a radical prostatectomy, we remove the prostate. So if you look on the diagram, you can see the bladder at the top, the urethra, which goes into the penis, and then the rectum in behind off to the right of the picture. The prostate sits right in the middle. The urethra goes right through the middle of the prostate. So when we perform a radical prostatectomy, we remove the prostate, and we remove what are called the seminal vesicles, which produce a fair amount of fluid that's involved in your semen. And so the seminal vesicles are gone. You will no longer make semen. You will no longer have any ejaculate coming out after surgery because there's nothing there. The prostate makes part of the fluid. The seminal vesicles make the rest. We remove the prostate in the middle picture, and then afterwards you take the bladder, do a little reconstruction on the bladder typically, and then you sew the bladder back down to the urethra. So you're basically just removing something from the middle, sewing things back together. And that's the basics of the radical prostatectomy. As I mentioned earlier, on Vancouver Island, everyone is performing an open radical prostatectomy. So there is no robot, and no one is performing laparoscopic approach. The laparoscopic and robotic approaches are available. Again, laparoscopic is recommended against in current guidelines because there's no real benefit to it. Robotic may have some slight benefits, but currently in BC, it's only offered in one location at Vancouver General with a fairly long wait list to go along with it as a result. And we talked about the small benefits of the robotic approach versus the open approach. In general, there was a thought with the robot that everyone was going to go home quickly, maybe even go home the same day. And there are a few places that are sending patients home the same day now. For my radical prostatectomy patients, they all go home day one after surgery. Maybe 5% or less will go home day two. And that's the same as most patients who are having a robotic prostatectomy. So the stay isn't much different. My incision is typically the width of my hand. That's how I mark out my incision on someone's abdomen. The radical or the robotic prostatectomy, you're going to have 6 incisions that are all 1 centimeter to 1.5 centimeters. So the additive or cumulative incision is about the same size in general. So again, small benefits of robotic versus open approach. But in the grand scheme of things, we're accomplishing the same thing robotically versus open. We make what's called a lower midline incision. So for anyone that's here or on Zoom tonight who's had the procedure, you're going to have an incision right down the middle below the belly button to the bone, the pubic symphysis, the pubic bone that's just above the penis. That's where the incision is. We then open the tissues up. We split the rectus bellies apart. So we don't typically cut through the rectus muscles, which is why a prostatectomy typically is not a very painful procedure. Many people go home, maybe take a few Tylenol 3s or Tramosets, but many of my patients are just going home on Tylenol and Advil. And so we split the muscles apart, pull them apart, and then we put our retractors in. And so through a small opening that's this big, we can perform the entire procedure. One of the main things with a radical prostatectomy is controlling bleeding during surgery. And there are 2 main steps at which we do this. So the picture on the left, what's called the dorsal vein complex. So imagine that this is looking down into someone's abdomen. What we see, can I get a, good. So what we see here, this is the prostate here, and there is a very large group of veins that runs right over the prostate coming back from the penis. And if you cut through this and don't do anything about it, it will bleed significantly very quickly. And so controlling the dorsal venous complex is one of the main steps to learn and to perform in a radical prostatectomy. The other main area of bleeding is controlling what are called the pedicles. The pedicles are the main blood supply actually to the prostate, and they are on the lateral aspect of the prostate. So if you imagine the prostate is like this, your pedicles are on one side and on the other side here. And so controlling those, there are multiple different techniques to do this, but having good control of those is crucial to minimize blood loss during surgery. Sexual function is always one of the big questions. The nerves that feed your penis, that allow you to get erections, not orgasm, but allow you to get erections, run within millimeters of the prostate. And they run you can see on the images here. So if we're looking, this is a cut right through the prostate from front to back, and you can see what's called the neurovascular bundle is running one on either side of the prostate. The side view of it shows those nerves in the yellow on the image, the large image, are the nerves, blue for vein and red for arteries. They don't actually come in that color in the body. Unfortunately, it would make life much easier for us, but they all kind of look the same when we get in there. And so we just see a packet of tissue, some blood vessels popping out of it, but a packet of tissue that determines whether you are going to have erections or not. If you have aggressive disease, if there is suspicion for disease that has spread just outside the prostate on both sides, usually it is not a good idea to try and spare the nerves. Sparing the nerves puts you at higher risk of leaving cancer behind. If you have lower risk or intermediate risk disease, your PSA isn't too high, and the prostate doesn't feel abnormal on the back, on the posterior aspect, then there's more of a chance that we can spare the nerves, and we can spare nerves on one side. So if the cancer is all on the right side, we may choose to spare nerves on the left. If the cancer is on both sides, but not near the outside of the prostate on biopsy, then we might spare nerves on both sides. And the lower the risk of cancer, then the higher the probability that we're going to try and spare nerves. If we spare both sets of nerves, there is still a good chance that your erections aren't going to be as strong as they were before surgery. But this is one of the main steps. If we want to save erections, save erectile function, again, not orgasm, that's completely different. You can get an orgasm without an erection. But if we want to save erectile function, we need to spare at least one side of the nerves. And then at the end of the procedure, we have taken out the prostate, we have a bladder, we have a urethra, and we need to somehow fit them back together. So usually we reconstruct the bladder and we close the bladder opening so it's about the same size as the urethra. And then you can see the little black sutures. And what we have are in the urethra, so where my cursor is there, there's a suture that goes in the urethra and then comes out and goes into the bladder. And so we have sutures that go from the urethra to the bladder. We typically put in somewhere between 6 and 8 sutures. 6 would be a standard approach. And then at the end of the case, we tie all of these sutures down, and that brings the bladder back to the urethra. We always do it through, or over, I should say, a catheter. So everybody with a radical prostatectomy is going to finish the procedure with a catheter in place. If we take the catheter out, guaranteed there will be some leakage of urine, and likely the connection will not heal up. There will be problems. So everybody has a catheter, typically somewhere 1 to 3 weeks. For most of my patients, it's around 10 to 12 days, depending on when I'm in clinic and can see them and get the catheter taken out. So catheter goes in at the end of the case. Everybody wakes up with a catheter after the procedure. So basics of a radical prostatectomy, and this is for the open approach. So surgical time, somewhere between 90 and 180 minutes. In my my OR day typically goes from 8 o'clock to 3:30, and we'll do 2 of these. So the first case, by the time you get put to sleep, it's 8:30, 8:40. We start our operation, and we're usually around 2 hours to 2.5. Some places will finish a little bit quicker. Some places will take a little longer. It depends if you're having a nerve sparing procedure. It depends if you're having lymph nodes removed at the time of your surgery. But generally, 2 to 3 hours would be pretty typical. Everybody gets a single dose of antibiotics. With this, there's no need typically to continue you on antibiotics for a long period of time. There's no benefit to it. So you get a single dose of antibiotics that goes in your IV that's given usually within an hour before surgery. Blood loss, typically between 300 and 600 milliliters. So 1.5 to 2.5 cups of blood would be typical blood loss. Yeah. So I tell patients the risk of blood transfusion is about 1%. So the chance of needing a transfusion is very low. It happens occasionally, but it is not a common occurrence. typically you would need to lose, if you come in with a normal hemoglobin, normal blood level, you'd probably need to lose 1.5 liters before there were any big concerns, unless you had heart disease or other major comorbidities or other issues, medical issues. So it usually doesn't even come close to requiring blood transfusion. Most men will have a general, well, everyone gets a general anesthetic. Sometimes you will have a spinal anesthetic plus general anesthetic, and what that allows for is to reduce the amount of narcotics you need for pain control during the procedure. I prefer just a general anesthetic. It's a little quicker to get things going, and the pain honestly isn't that bad, so it's not usually necessary, but it all depends on what site you're at and what the preferences are there by your surgeon and the anesthesiologist who's treating you. Most patients will stay in hospital 1 to 2 days. Again, 95% of my patients will go home day 1 after surgery, and a few Tylenol 3s and regular Tylenol and Advil for pain control. You get taught how to use the catheter, how to drain the catheter, and how to look after the catheter by the nursing team on the ward after surgery, usually 1 to 2 weeks with a catheter in place. Now I'll pause just before we keep going. Anyone have questions either here or on the call? Nothing.
I'm wondering, given the length of the incision, that infection doesn't come up as a concern.
So post-operative infections, you can have different types of infections. So you can have bladder infections, that the urine itself gets infected. You can have incisional infections. So again, it's an incision about this long, 10 to 15 centimeters long, 4 to 6 inches. And the infection rates after a radical prostatectomy are probably going to be in the 2 to 3% range with a single dose of antibiotics. And so it's not a high risk procedure. It's not like a bowel resection. Usually you get more antibiotics for something like that, but urine is relatively clear, relatively sterile. There are some bacteria in there, but it's uncommon to see an infection afterwards. Did you have a question?
I just wanted to make the catheter, you don't change the catheter as frequently?
Not at all. We do not want anyone touching the catheter. So once the catheter is in there, let's say that it gets taken out 2 days after because something goes wrong. That's a potential disaster for us to have someone who doesn't know what's just happened pop a catheter out, shove a catheter back in, and the catheter may, because the tissue hasn't healed, it could easily, instead of the connection, sorry, I'll show it to, if the connection is here, instead of the catheter going in the hole in the middle, the catheter may hit something, hit a suture, and end up outside of the bladder. And so no, the catheter stays in with instructions. Nobody else touches this. If there's a problem, you talk to a urologist.
4 or 5 years ago, there used to be
Okay.
And they showed about
yeah. Yeah. So for some people who can't pee, we teach some people to self-catheterize, but for people with prostate cancer having a radical prostatectomy, the catheter is in until we tell you to take it out. And then once it's taken out, we don't want anyone trying to put a catheter in there. I had one patient, this is the first patient I've had since starting in Duncan, who couldn't pee afterwards. So we took the catheter out and he wasn't able to pee. And he did have a catheter slid in by someone else. Fortunately, it went in the right place and there were no complications, but it just took a little while. The opening was a little bit snug and it took a little while for the swelling to settle down, and he's peeing now just fine. But he had to have a catheter put back in for an extra week. So after everything's healed up, if you go 2 years later, if there's a problem, but it's very rare to run into urinary retention, the inability to empty the bladder after a radical prostatectomy. Again, most men will have troubles with leakage as opposed to not being able to pee.
There's just a question in the chat room about the age of someone who's a candidate for radical.
Yeah, so I'm not sure, can people hear you as well?
No.
Okay, so question in the chat about age for patients who are looking at radical prostatectomy. So in general, I don't have set limits on age, because you will see some men who are 75 years old and look like they could be 50. And you'll see some men who are 50 years old and are having trouble getting up onto the exam table. And so age is not the main criteria. In general, though, if you're over 80 years old, it's going to be very difficult for you to look good enough for a surgeon to want to operate on you with a radical prostatectomy. Other surgeries, definitely, but radical prostatectomy, unlikely. The oldest person I think I have done is about 76. I had someone who was 79, and I offered them a referral to someone else, over to Vancouver General, or to one of the oncologists here in Victoria. We're a small site in Duncan, so I'm not going to really push limits there. But if you're in your early 70s, I think both options are very good for you if you're in reasonable shape and don't have too many other issues. Again, if you have horrible heart disease, you've had 2 bypass surgeries, you have heart failure, your legs are swollen, and you can barely walk from here to the side of the room, you're probably not going to get treatment of any kind for localized prostate cancer, because probably something else is going to kill you before prostate cancer does. Treatment for localized prostate cancer, we're looking at treatment outcomes 10, 15, 20 years down the road, unless you have very aggressive disease. So for people, there's no set age. It's something you talk to your surgeon, you do your research, you look into complications, and you can ask honest questions to your surgeon. What do you think? What do you think about me having a radical prostatectomy? What do you think about me having radiation? A lot of people, it's based on personal experience. It's, oh, a friend had radiation, he's doing really well, or a friend had surgery and he's doing awful. I don't want that. And so you can have bad outcomes, you can have good outcomes with radiation or surgery. So there's no correct answer for everyone. You have to do your research, you have to look into things, think about the potential complications, potential benefits, and then go from there. Did that answer the question? Sorry for no specific age cutoff. Yeah.
Yeah, I have a question too. I had a
Yeah.
But it all went well, except just there was some scarring afterwards, and so that complicated his ability to urinate.
Correct. So scar tissue, I'll talk about that a little bit later.
Okay.
Potential complications are relatively low, but it is possible where the opening where you sew things back together, if the tissue doesn't heal up properly, it can either not heal and you have a gap, or it can scar down, and instead of an opening that is this big, you have an opening that is this big and it's hard to pee. Yeah. Yeah.
Just the catheter removal thing. I had a radical prostatectomy.
Yeah.
The catheter.
Yeah.
She was unable to contact my urologist, but after a plan to have urologic instructions for something to take it out. As a consequence, there was scar tissue formed, where we ended up having a resection.
Yeah.
To deal with the scar tissue. So it can be a complication to.
So just for people on the Zoom call who may not have heard all of that, it was a story about someone who had radical prostatectomy, had bleeding around the catheter, a nurse took the catheter out without being able to check with the urologist first whether it was safe to do so, ended up with scar tissue formation and some complications associated with that, requiring a second procedure. And so, yes, there are potential complications, and typically the hope is that if we have a nurse remove it, so sometimes usually I bring patients into the office and I take it out afterwards just for a quick check in, see how they're doing, see how everything's going so far. But sometimes that doesn't work if I'm away for a week or something like that, or I don't have clinic for 2 weeks, and I don't want you to sit with a catheter for 2 extra weeks because I'm in the operating room or doing other things for a long period of time. So sometimes we do have nurses remove it. Some surgeons, that's their standard. You have home care nursing take the catheter out. And if there are concerns, then it's up to the nurse, but it's also up to you as the patient to say, okay, let's hold off and wait till we can get word from the urologist, from the surgeon, to figure out what to do. We can take maybe one more question now, and then we'll just keep going. Was there anything else right now? Okay. So things that you can do pre-operatively. So once you've been diagnosed with cancer, you've said, okay, yes, I'm going to go ahead with a radical prostatectomy. There are things that I tell my patients that I think are helpful. Number one, do your research, okay? Know what you're getting yourself into. If you just show up and say, great, radical prostatectomy, my friend had it, he did really well, and you show up, you might be a little shocked by the fact that it's surgery and it actually takes quite a bit out of you. It is still a major procedure, even though it's a relatively small incision. It's still a big undertaking. And so you're going to be tired. You're going to be fatigued for a good month, 6 weeks sometimes. Your appetite's going to be off for a little while. You're not going to be able to exercise or lift heavy things. So if you're, for some men still working, you're going to need to take time off work and take it easy for a little while. So make sure you do your research about both surgery and radiation, because you want to know both sides of the story. If you just come talk to me, I'm a surgeon, I can tell you about radical prostatectomy, but I can't give you as much detail about radiation because I'm not a radiation oncologist. And like I said at the beginning of the talk, there is inherent bias when you talk to a surgeon about a surgical procedure. No matter how hard I try, I'm still a surgeon. I like operating. And so there's going to be some kind of bias no matter what I do. So do your research, ask good questions, okay? Talk to people who have gone through treatment. Again, talking to one person is helpful. When you have a group like this, you may be able to talk to multiple people who have had surgery or radiation, and then you can hear the side effects. You can hear, oh yeah, this happened, or this may happen, as opposed to you talk to one person, everything was great, go ahead, have it done. Nobody's the same. Everyone's going to respond a little different to treatments. Make sure you discuss your options with people you care about. So your spouse, your partner, loved ones, if you have kids involved, make sure that you don't just sort of put your head down, think I have cancer, oh no, this is awful, and just make a rash decision. Talk to people, get other ideas, other opinions, because those opinions do matter. And then talk to your surgeon. So we've mentioned a few of these things as we go along. Talk about potential complications. Talk about whether they think you're a good surgical candidate. Again, if you're 85 years old and you say, I want a radical prostatectomy, your surgeon's probably going to talk a little sense into you and say, this is not a good idea for you because of, and walk you through potential complications and the fact that complications are much higher as men age. And then you can talk about if sexual function is important to you, talk about nerve sparing. You can ask, can we spare nerves? What are my chances if we spare nerves? And so you can go through that as well. And so these are things to think about and prepare for before you ever make it to the operating room. Other things, get in shape, okay? I had one patient and I told him, he asked me, he just said, what can I do to prepare? And I told him, a bit of a belly. I said, you need to lose some weight. I said, you lose weight, your complication rates go down. My job is much easier. And when my job is easier, surgery usually goes smoother. He lost 30 pounds in about 2.5 months from the time he was diagnosed to the time he had surgery. He looked great. So he came in excellent shape. So get yourself in good shape. If you're in good shape before surgery, you'll be in better shape as you recover, and you'll recover quicker. Kegel exercises or Kegel exercises are pelvic floor strengthening exercises. For men here who have been treated for prostate cancer, this is something that you have probably done. It is where you work to strengthen your pelvic floor muscles, particularly focusing on your urinary sphincter. Because after the prostate comes out, you lose what's called the intrinsic or internal sphincter, which is between the bladder and the prostate. And then you just have your external sphincter left over, and it needs to work extra. And it needs to get stronger in order for you to be able to be dry and not have to wear pads. So the Kegel exercises, there is no good evidence that Kegel exercises before surgery is helpful, but there is good evidence to say that being in good shape beforehand minimizes your complication rates afterwards. And so I usually tell men, you might as well start now so you can potentially just develop a habit for afterwards once you have surgery and actually need to do the exercises. Quit smoking. If you smoke, your complication rates are higher, particularly the question was asked earlier about infections. Infection rates are higher for patients who smoke, and other complications like urine leaks and other pelvic collections are higher. Tissue does not heal well in patients who smoke, as opposed to those who don't smoke. So even if you smoke 2 packs a day, if you can cut back, that's better than continuing. If you can quit a month before surgery or 2 weeks before surgery, you will have a smoother course than if you continue smoking all the way through. And then look at other modifiable risks. So if you have diabetes, make sure your diabetes is in good control. If you come in with sugar levels that are through the roof and your A1C is really high, then you're going to have a higher risk of complications, particularly infections and poor healing. If you have high blood pressure, make sure that gets controlled beforehand, because you're going to have higher complication rates with things like heart attack or stroke at the time of surgery. And so you're going to have some risks there. And then alcohol intake for everybody. Again, if you're drinking a dozen beer a day or even a 6-pack a day before you come in for surgery, you're not getting the nutrients that you need for your body to heal properly. So cutting back on alcohol is also important. And then what I tell everybody is, most of the time I say, okay, here are the options. You can have surgery, you can have radiation. And people say, well, what are the side effects? And I go through the side effects and they look at me and they're so disappointed, because you're treating cancer and there are side effects. And both treatment options, surgery, radiation, something's going to happen. Something is going to be different after treatment than before. Your life will not be exactly the same. And you need to understand that we are treating cancer. This is something that is a serious diagnosis. And the treatments for big diagnoses like cancer usually have potential side effects. Then post-operative, so you will wake up with a catheter. We mentioned that earlier in the talk. Pain is not typically severe. If you're having horrible pain, there may be something going on, and it's something to bring to the attention of your urologist or family doctor or someone who's looking after you. Again, most people are not going to have severe pain after the procedure. And I tell my patients, if you're the first person of the day, I expect that you're up walking around the evening of surgery. Okay, we expect that you need to get back to some normal movements and some normal activities, and not think, oh, I just had surgery, I'm going to sit around on the couch for a week and a half and let someone feed me and not do anything, because that's bad for you. And that's not going to help your recovery. And it's going to put you at risk for, number one, for blood clots, which is one concern that we'll talk about in a minute. And then, okay, or right now. So after surgery, you will typically, for open radical prostatectomy, guidelines would suggest or would recommend a blood thinner, typically given for 1 month after surgery. This is usually given as an injection. It's a heparin-like medication. Dalteparin or enoxaparin are the most common ones used. It's the same type of thing that's used after a hip replacement or a knee replacement, because the risk of what's called a DVT, or deep venous thrombosis, is quite high after surgery compared to just regular life. So we want you up moving around, because the more you move, the less chance you are going to have of having a blood clot. But these blood thinning agents can be helpful. They reduce the risk from a little over 1% to less than 1%, which getting these blood clots then means you're stuck on blood thinners, higher dose blood thinners, for 3 to 6 months, sometimes longer. So we prevent with a fairly mild medication with few side effects. And in doing so, we avoid these major complications, or what could be major complications. Nobody's going to have an erection the morning after surgery. Okay, first of all, you're going to have a catheter, and so you're probably not going to want an erection. But even after the catheter comes out, erections do not come back right away. I had one patient, I saw him 2 weeks after surgery, and he already told me he was getting erections, and I was shocked. I'm like, no, this doesn't happen. But he was actually getting erections. We'd done a bilateral nerve spare, and it went really well. But that's not typical. Most men will take up to 2 years to have their final outcome for erectile potential. Okay, so it's not something that happens overnight. It is something that can take quite a while. And so erections are something that do not come back right away. And everybody will leak urine afterwards. Nobody will go have the catheter taken out and not leak. So I tell guys when they come in, bring a pad with you or even a pull-up. Depends. Something you're going to pick up at the pharmacy, because almost guaranteed you will have fairly significant leakage up front. Some men do okay. Some men will have leakage that is persistent. We'll talk about that in a little bit. Complication rates. So this was from it's called Up to Date. This is from meta-analysis of about 50 studies looking at radical prostatectomy. So just some of the potential issues. So urine leak, 1%. As I was coming down today, I had my wife had been talking to a family friend who knew somebody who had a prostatectomy and was hoping to talk to me. So I called this person as I was coming down, had his surgery 6 months ago, had a big urine leak. It's not a common complication, but it does happen. Stricture or contracture, where things scar down, up to 10%. Now, most of these don't require treatment, but a small percentage of them would require going back in and doing a transurethral resection, just opening up the scar tissue, which is a second procedure, which is a very minor procedure, but it's still another surgery. Nerve injury is very low. Rectal injury, less than 1%. Rectal injury increases the more aggressive the cancer is, especially if it is starting to invade posteriorly. For people like that, if we can see that on the MRI or on preoperative imaging, usually we're going to lead you towards radiation as opposed to doing surgery. Blood clot formation, the venous thromboembolism or DVTs. Lymphocele is when we do a lymph node dissection. If we don't clip off all of the lymphatic channels, or if a clip falls off, then you can have lymphatic fluid that leaks into the area around where you had surgery, builds up a collection, and can cause some pain, and we have to put a drain in. Happens uncommonly, but we do see it every once in a while. And then at the bottom, we have the two main issues, erectile dysfunction and urinary incontinence. If you look a year out from surgery, the quoted rate is about 10% of men are still going to be leaking significantly. Leaking enough that you're wearing a pad, or maybe wearing more than one pad a day. Some guys just keep a pad in, they leak maybe 2 drips a day, but they want a pad just for safety. But about 10% will have more than that. Erectile dysfunction, it all depends on the nerve-sparing approach. If your nerves are not spared, you will not have erections. You can still have an orgasm, but you cannot get an erection because the nerves are gone that provide that. There are options for that, and we'll talk about that in a minute. And so just coming close to the end here, long-term expectations. So cancer control. Radical prostatectomy is an excellent curative treatment, as is radiation, for men with localized prostate cancer. If you look 10 years out, there is about a 1 in 3 chance that you will have a PSA recurrence, that there will be potentially some cells that were outside of the prostate already before you had your surgery that weren't known about, that you can't see on any test, that you can't pick up anyway. Sometimes it will be during surgery, a little bit of cancer was left behind. That's another possibility as well. So up to 1/3 of patients will have a PSA recurrence. Now, that doesn't mean you're going to die of prostate cancer. That just means there is still some cancer left over. And then you have radiation as an option to treat that a second time. So that's one of the nice things with surgery. If you do have a recurrence, you can then try radiation. And so radiation success is not as high for these salvage treatments as for patients who have radiation up front, but it's still something that's going to slow down whatever cancer is in your body. Erectile function or dysfunction, again, penile sensation, orgasm are not controlled by the nerves that are affected in a radical prostatectomy. So you still have sensation, you can still have pleasurable sensations, you just won't get an erection. You can still have an orgasm. So sexual activity sometimes needs to change afterwards. If you have a partner, you may not be able to perform penetrative intercourse. But if your partner is willing and you're willing, you can still enjoy sexual activity. You can still have pleasure from it. And so that's something that I highlight to all my patients if things aren't working as they expected. Return to function, as I mentioned earlier, can take up to 2 years. So it is not a quick process. The nerves are damaged at the time of surgery, and then they slowly recover function. And penile rehabilitation, for people who have been treated previously, you may have taken something like Cialis or Viagra after surgery. There's a thought that if we can give you medications that improve erectile function early after surgery, that it seems to make sense that you'll get function back sooner, or maybe we'll even improve your overall outcome. So there's a sexual health center in Vancouver that I send patients to occasionally with a sex psychiatrist, with a urologist, with counselors, and they will give you a penile traction device to try and stretch the penis out a little bit. They'll give you a vacuum device to try and bring blood into the penis shortly after surgery, and you'll often get treated with something like Cialis or Viagra, which are the common medications used to help with erections. And so the thought is, let's try and improve blood flow. Let's not just let the penis sit for 2 years while you're recovering. If you don't use it, you might lose it, is kind of the saying. But there's no good evidence that it works. So most of my patients, I don't treat them with Cialis unless they're really eager. And if someone says, look, sexual function is very important and we've spared nerves, then we get them on Cialis and we see how they do. There are other options like injections into the penis. You can have a tiny little needle, put some medication in a syringe, inject directly into the penis. You don't need nerve set. It's the most effective way without going to a penile implant or a prosthesis for men to get erections. And so for sexual function, these what's called trimix, it's a mixture of 3 different medications. We use that, and you can start using that not too long after surgery if you want to start engaging in penetrative intercourse or having erections. So that is an option. So there are lots of options for erections, even if you can't get it naturally. And then the incontinence. So again, about 10% of men at a year will have leakage that they're still wearing pads. It's a slow and it's a challenging process. I see people typically a couple weeks after surgery to take the catheter out. I see people at 3 months, and then at 6 months in a year, or at 9 months in a year. And what I always hear is, I don't think I'm improving. And you're like, okay, well, how many diapers are you wearing? Like, well, I started in diapers and I would use 2 diapers a day. And I said, well, I'm not wearing diapers anymore. I'm just using pads. So you are improving, but you don't notice it because it's such a frustrating thing. And so you have to be patient. You have to do your Kegel exercises, and you just have to give it time. Your continence will improve over time. About 1% of men will go on to have a second procedure. So I saw someone today, he had prostate cancer treated with a radical prostatectomy. He then had radiation. He developed some scar tissue at the opening between the bladder and the urethra, and unfortunately developed a bladder cancer. So I put a cystoscope in his bladder. We took a quick look. This was probably a year ago, and he had a bladder tumor. So then I had to take him to the operating room. But unfortunately, when we got to the operating room, the opening was too small to fit our standard camera. So I had to open things up for me to be able to get the camera in to treat his bladder cancer. And after that, he developed leakage. The only thing that was preventing his leakage was because things were so tight that was protecting him. And so now he has leakage, and I'm just referring him down to look at what's called an artificial urinary sphincter. This is a device that wraps around the urethra, fills with fluid. You have a little reservoir in your abdomen, and you have a little pump in your scrotum, like a third testicle. And when you want to pee, you pump the pump. It gets the fluid out of the cuff, and everything opens up and you can pee. And when you don't want to pee, it just closes up on its own until the next time that you pump it a few times. So that's an option. There's also something called a male sling, which puts pressure up or support up under the urethra and can be a good option if you have mild incontinence that you want to get rid of for the patients who are, say, still playing pickleball 5 days a week and don't leak ever except for occasionally at pickleball. And they want to get rid of that so they don't have to wear pads when they play pickleball. So that's male sling, artificial sphincter are options there. And with erectile function, there is the option of a penile implant or prosthesis as well, if that's something that's crucial for you. So those are our basics. That is my talk. and I'm happy to answer questions if people have questions. That was a fairly brief overview. There's a lot that goes on. I did not get into the psychological aspects, the emotional aspects and relational aspects that come along with radical prostatectomy, but that's probably something that is actually critical in terms of expectations. Your sex life will change if you're still sexually active. You have a diagnosis of cancer, which is a significant thing, even if you don't really realize it in the first place. And you're undergoing major surgery. So from the psychological or emotional perspective, there will be changes. You will not be the same person after you have surgery or after you have radiation as you were when you went in. And it's something you have to accept. Work against, if you have incontinence, do all your exercises and try and prevent that. But you do need to realize that things will.
Yeah, so I'm recently discovered prostate cancer.
Yeah.
And so I talked to surgeons and then I talked to the oncologist.
Yeah.
So the oncologist would suspect me that I'd be on a hormone therapy.
Correct.
For a year and a half or something.
Yeah.
And then radiation.
Yes.
Then I would think, and then there's a surgical option, straight to surgery. But then I now technical stuff again.
Oh, yeah. The
So
GUNS trial.
I'm actually now dealing with hormone therapy, then leading up to the.
Yes.
So I'm just curious why that isn't sort of statement. There's a standard kind of option.
Yeah. So for people who are on the Zoom call, the question was, so we have a man here who is just sent to a radiation oncologist, had opinions from both, and then in the end has been put on a clinical trial. And this is the trial that I mentioned. It's over in Vancouver right now, looking at men with high-risk prostate cancer, high PSA or very aggressive-looking disease, potentially with nodal involvement, and potentially even with a metastatic deposit. So they are looking at all sorts of different options. And what they're doing is they're taking the hormone therapy that is often used along with radiation for 6 months to 2 years. And they are combining that with novel agents that are usually used only for patients with metastatic prostate cancer. So what I can tell you about your question, why doesn't everybody get the hormones? There have been 2 good studies out of UBC done by Larry Goldenberg, who was the previous head of the department, with Martin Gleave when Gleave was earlier in his career. Very clear data showing that hormone therapy before radical prostatectomy does not improve outcomes. So that's why that's not used, because there is a good randomized studies to say it doesn't work. But the thought is, if we combine it with these newer agents, will it help? The way that drugs get tested in prostate cancer is that first they get tested in men after they've had every option. Metastatic disease, they've gone through round 1, round 2, round 3, and then clinical trials. And then they show benefit in clinical trials, and they say, okay, well, what if we move it sooner to round 2? Okay, now what if we move it to round 1? And that's what's happening with all these drugs. And now they're saying, what if we move these drugs to before surgery or before radiation? And that's what the GUNS trial is looking at. It's an excellent trial. It's hopefully going to give us great information that may radically change how we look at surgery, how we treat men with prostate cancer, hopefully giving us much better outcomes. Or they may find it makes no difference. And that's why there's the trial. Unlikely that it's going to harm you significantly. Maybe there's some small risks, but it's this is why we do clinical trials. But it's a great study, and thank you for being involved, because it will help answer questions for all the men that come after you who want the best. Anything online?